Hi, everyone. Welcome to the second Mission Impact volunteer call of March 2025, covering improving lives. Today's presenters from Breakthrough T1D are Jonathan Rosen, Courtney Akafi, and Amin Ghavami Najad.
Sandy, thank you for the introduction. We're all really excited to update this group on the important things happening in our Improving Lives program at Breakthrough T1D. I want to start by saying that just like all of our programs at Breakthrough T1D, we cover everything from bench to bedside. It's not enough just to fund discovery research and then hope that it somehow results in improved outcomes. We support efforts to make the discoveries, test them in clinical trials, get regulatory approvals, and then get payer coverage. And only then can we see better outcomes in people with type 1 diabetes, and that's the standard by which we judge ourselves. Over the course of this presentation, we're going to show you some examples of how we move products along this pipeline. At Breakthrough T1D, there are three major scientific programs. You've previously heard about our work in disease-modifying therapies and cell therapies. Today, we're going to be talking about our work in improving lives. We've come a long way toward improving lives of people who live with type 1 diabetes, and we're going to keep going. In the old days, people measured their glucose by finger sticks. There were limited options available for insulin therapy, and even less that we could do for long-term complications and the mental burden of living with type 1 diabetes. Today, thanks to our efforts and those of others, we have great new diabetes technologies, including continuous glucose monitors and pumps that talk to CGMs for automated insulin delivery. We have emerging therapies for long-term complications and mental health. And importantly, many of these therapies are covered by payers. Challenges remain. Most people with type 1 diabetes don't achieve their glucose control targets, and broader metabolic control outside of glucose is hardly addressed. We need to continue to reduce long-term complications, address the burden of living with type 1 diabetes, and mental health issues. At the end of this presentation, we'll come back to the slide and show you what we think the future holds. The Improving Lives program has 4 different areas where we support research: devices, insulins and adjunctive therapies for metabolic control, complications therapies, and behavioral therapies to deal with the mental and emotional burdens of type 1 diabetes. I'm going to start by telling you about some work going on in the insulin field. This is a figure showing basically 100 years of insulin development. And just at a glance, you can see how far we've come. We used to get insulin from beef and pork sources. Then we figured out how to make insulin in the lab and scale it up. And now we have great new analogs, fast-acting analogs for meals, long-acting basal analogs, and even an inhalable insulin called Afrezza. But we still have further to go. And the reason we know we have further to go is that most people with type 1 diabetes still aren't achieving their glucose control goals. And it's obviously not the fault of the people trying to do it. It's that the tools available just aren't good enough yet. Breakthrough T1D focuses on 3 kinds of products that we refer to as next generation insulins, or next gen. One is liver-targeted insulins. This is important because in someone without diabetes, insulin made by the pancreas goes straight to the liver where it has important benefits. And with insulin drugs in type 1, most of the insulin doesn't get to the liver, so it doesn't work as well. The second one is ultra-rapid insulins. You'll hear more about that later in the presentation. But for now, suffice it to say, the currently available injectable insulins just aren't fast enough. And the third is glucose-responsive insulins, which I'll tell you more about now. GRI, or glucose-responsive insulin, refers to the next generation of insulins we're working toward, which are designed to be active at high blood sugar and inactive at low blood sugar. This means you can take it, it'll stay in your system throughout the day and regulate itself so that your blood sugar goes down when it's too high, but it doesn't go down when you're approaching hypoglycemia. We think this will have both clinical benefits in terms of A1C, time in range, and hypoglycemia avoidance, as well as mental health and quality of life benefits, because you won't have to think about your diabetes management as much, and you won't have to fear hypoglycemia as much. This field is moving forward slowly but surely. We are currently supporting several ongoing preclinical GRI projects, which are advancing different technologies and are at different stages of development. In the past, we've partnered with major insulin manufacturers, including Sanofi, Eli Lilly, and others to support GRI projects. A particular success story we're very excited to talk about is One Protomer Technologies. This is a small company that we funded to develop a glucose-responsive insulin several years ago. Then the T1D Fund, which is our venture capital arm, provided some investment. Then they were acquired by Eli Lilly to advance the technology further. And last, I just want to make the point that even beyond the research we've funded, we've catalyzed the whole field. We've held meetings, we've brought others into the game, and now we see projects in preclinical stages being pursued all over the world. It's a challenging topic. There's no drug like this on the market in any disease, but we think that it'll be worth it when we finally have one of these drugs. One of the surest signs of progress we see is that the major insulin manufacturers, Novo Nordisk and Eli Lilly, both have glucose sensing insulins listed on their publicly available websites under phase 1, which is sort of the earliest human clinical trials. Although we don't know much about what happens inside the companies, it's incredibly exciting and important to see that this is something that they're working on. Now I'm going to turn it over to my colleague Amin to talk about some of the important work we're supporting with devices.
Thank you, John. For the next few minutes, I'll be discussing updates on devices for type 1 diabetes. We are very excited to share that there has been significant progress in diabetes technology over the past year. At the top of our list of devices is AID, or Automated Insulin Delivery System, which was once known as the artificial pancreas. An AID system includes an insulin pump that connects to a CGM and automatically adjusts insulin delivery based on real-time data from an algorithm. Breakthrough T1D has been at the forefront of advancing this technology. The progress in this field has been incredible. Just compare the early version of AID to what's available today. Devices have become smaller, smarter, and more user-friendly, making a real differences in people's lives. Today, the type 1 diabetes community has multiple AID systems to choose from, allowing people to find what works best for them, expanding these options, and making AID system even smarter remains one of our priority at Breakthrough T1D. As I mentioned earlier, Breakthrough T1D has been a pioneer in this field, but we are not just a funding organization. We actively support research and ideas from the lab to market. AID systems are a great example of how Breakthrough T1D is truly improving lives of people with type 1 diabetes. Look at this graph. In 2005, we launched the Artificial Pancreas Project, supporting groundbreaking research from top scientists. In 2012, the first outpatient AID trial was approved by FDA with funding from Breakthrough T1D. In 2017, the first hybrid closed-loop system became available. And today, we are excited to see even more hybrid closed-loop system on the market, giving people with type 1 diabetes more choices. And at every stage, Breakthrough T1D was there, supporting the researcher and companies making this happening. We are also excited about the progress in devices over the past year. In this slide, I'm just highlighting 3 of these devices. We do have another insulin pump, which has been approved recently, and there are now even more CGM options available. New sensing technology compared to the traditional enzymatic approach are bringing fresh innovation to the field. These advancements show how quickly diabetes technology is evolving, and we are looking forward even more breakthroughs in the near future. Beyond AID system, which I'll cover in the next slides, we have also seen exciting progress in other diabetes technology. One example is CGM-CKM, which has shown promising clinical results. You already know about the CGM, or continuous glucose monitoring. Now imagine adding another critical feature, which is continuous ketone monitoring, or CKM. For some people with type 1 diabetes, DKA or diabetes ketoacidosis is a serious complication. It can come on fast, often without warning, and land people in the hospital. But what if we could catch it earlier? That's where CKM can be a game changer. It tracks ketone level in real time, giving people a heads up before things get dangerous. This means fewer hospital trips, less stress, and more peace of mind for both people with type 1 diabetes and their families and caregivers. We are actively supporting several projects in this space, continuous ketone monitoring. And we are not stopping there. We are also looking ahead to the next big advancement in diabetes technology. In the past, we were supporting a user, for example, a user-friendly insulin pumps. And in the future, this could mean a CGM and insulin pump combined into one device, or even smaller, smarter pumps that make life even easier for type 1 diabetes people. When it comes to automated insulin delivery system, or AID, we know there is still room for improvement. One major challenge with current hybrid closed-loop system is the need for manually estimate the food intake. Sometimes we want really to eliminate this. We strongly believe that AID system should be fully automated around meal, with no manual input required from the user. There are a few ways to make this happen. One is to use a faster acting insulin with rapid on and off kinetics. Another approach to make this AID actually completely automatic around the meal, it would be to using adjunctive therapies like the GLP-1 in addition to insulin. Also, smarter algorithms that can be potentially powered by AI or machine learning can really make a difference here and can make the AID more smarter. At Breakthrough T1D, we support any innovation that helps us get closer to this goal. We recently launched a request for application to support the development of devices and drugs aimed at achieving fully automated insulin delivery at meal times. We are happy to have received many high-quality proposals and look forward to announcing some exciting new projects very soon. At Breakthrough T1D, we are not just focused on the science. We also recognize the real-world challenges around adoption and payer coverage. It's great to see adoption increasing, but the reality is that not enough people are using AID systems yet. AID system adoption is lower in the whole US population than in its cohort. The guidelines are clearly say people with type 1 diabetes should be offered AID, even at diagnosis, and we are not yet close to achieving that standard of care. There are multiple factors limiting AID system uptake, including lack of healthcare provider readiness or expertise, especially in adult type 1 diabetes care, the shortage of the endocrinologists and diabetes educators, and rushed medical appointments. Our new medical affairs department works to improve healthcare provider readiness and competencies in emerging type 1 diabetes therapies. And they will be presenting the MIV group next month. Beyond adoption, coverage has also been a major priority for Breakthrough T1D. We are directly engaging with the health plans and advocating for better access. The good news is that we have seen significant progress. Today, most commercial insurance plans and Medicare cover these devices, and now some states are even extending Medicaid coverage to children. There is still work to do, but we are getting there step by step. With that, I'll hand it over to Courtney.
Hi, everyone. I'm Courtney. I'll be talking to you about our adjunctive therapy strategy. In parallel to the development of new devices and next-gen insulins, we realized that insulin therapy alone is not enough to achieve optimal glycemic and metabolic control. Adjunctive therapies can be used to complement insulin to achieve those glucose targets, improve metabolic control, and to lead to the prevention of complications. And we know this is greatly needed. Up to 70% of people in the United States do not achieve their glucose targets. Obesity is a rising concern, and still some people with type 1 deal with long-term complications. So it is important to refocus our management strategy to be more comprehensive. Our goal is to drive development of new or existing products and influence the clinical care guidelines to make these additional therapies part of the standard of care. Clinical development and regulatory approval requires industry sponsorship, but unfortunately, people with type 1 are often excluded from these trials. So Breakthrough T1D is filling this gap. We hope that our funding of clinical trials will de-risk type 1 drug development by building the body of evidence for safety and efficacy with these drugs. One such drug that I'm sure we're all aware of is Ozempic, or semaglutide. This drug is part of a class of therapies known as the GLP-1 receptor agonists. These drugs are a metabolic control powerhouse. GLP-1 is a master regulator of glucose control, appetite, and inflammation. The goal of these studies is to understand the benefits of Ozempic, and there are so many benefits to target: glycemic control, metabolic control, treatment of cardiorenal complications, and we're including many T1D populations. We will not let people with T1D be left behind in this metabolic control revolution. These studies are ongoing, but I know at least one of these studies will present their findings this year. In the meantime, we know that people are taking these therapies. In the past few months, a bunch of real-world studies that look at historical data have been published. Real-world evidence studies are observational studies, not randomized control studies, which are the gold standard of scientific evidence. But these studies give us an indication of the power of these therapies. These therapies have shown that GLP-1 therapies cause a decrease in body weight, a decrease in A1C, while also requiring less insulin. These findings are promising, but we still need large randomized control clinical trials with these newer GLP-1s for people with type 1. So more research is needed. People with type 1 need therapies to address not only glucose control, but also insulin resistance, inflammation, and other metabolic imbalances. Promising therapies are currently being developed for other diseases, and we think that some of these therapies developed for type 2 diabetes, obesity, cardiorenal disease, and liver disease can target these pathways that are and be repurposed for type 1 diabetes. And so a couple of months ago, we launched this new initiative to fund proof of concept studies to test this hypothesis. We have a bunch of projects that we've reviewed for this call for proposals, and I'm excited for next year to tell you about them. So what do we think the future of T1D care should look like? First, we need therapies beyond insulin. There are therapies on the market or currently in development for other metabolic diseases that we think can work for people with type 1. We just need to test them in trials. Type 1 management currently is too burdensome. The future of T1D care will be more convenient with oral drugs, weekly, maybe even monthly injections. We need to shift the paradigm. Glucose control is just not enough, and comprehensive metabolic control and the prevention of long-term complications is key for longer and healthier lives. And then finally, we need to maximize the benefits, targeting the needs of each person with type 1 diabetes. T1D care should not be a one-size-fits-all. We're excited about the progress that we're making in these adjunctive therapies, and we really believe we're on the verge of making significant change to type 1 care. Now I'll pass it on to John to talk about our complications portfolio.
Thanks, Courtney. Now I'm going to tell everyone about the exciting work we're doing in complications. The good news is that the rate of long-term complications in type 1 diabetes is going down, thanks to improved glucose control, improved management of blood pressure and cholesterol, and other factors. That said, any occurrence of long-term complications is too much, so we continue to lead the field here. Cardiovascular and kidney disease together are responsible for the majority of mortality in type 1 diabetes. And as I'll explain later, there are great new drugs transforming outcomes in type 2 diabetes, kidney disease, and heart disease, which we're now testing in type 1. In diabetic retinopathy, the case is quite different. There are a lot of new therapies improving outcomes for retinopathy, but we're still not satisfied with the state of the field. We want to support new therapies which are less invasive, have even better efficacy, and fewer barriers to access. I'm going to start by briefly telling you about a couple exciting things happening in the retinopathy field. The newest retinopathy drug approved is called Susvimo, which was approved just last month in February 2025 for diabetic macular edema. This is what's called an anti-VEGF therapy that's unique in that it's administered via implant and can be refilled once every 6 months, as opposed to other ones, which are injected once a month or a little bit less than that. Breakthrough T1D has a long history with this type of drug, again called anti-VEGFs. We supported the earliest research linking this molecule to diabetic retinopathy, and even supported clinical trials with an approved therapy, Lucentis, demonstrating its efficacy for diabetic macular edema. We're excited to see that the anti-VEGF field continues to blossom and produce new drugs for retinopathy. At the same time, we're interested in other types of drugs and other targets. One that we've been working on quite a bit is called fenofibrate. This is a generic lipid-lowering medication. One of the great things about it is that it's safe, convenient, and inexpensive. This is what's called a repurposed drug, meaning it was developed for one indication, and now we're trying to bring it into retinopathy. Recently, a trial in the UK called LENS read out, which provided very good data arguing for this drug's efficacy for diabetic retinopathy. There are also ongoing trials that we're supporting in both the US and Australia, one of which is in collaboration with the DRCR Retina Network, NIH, Roche, and our colleagues at the Helmsley Charitable Trust. Now onto heart and kidney disease. As I alluded to, there are great new heart and kidney therapies available for people with type 2 diabetes and even people without any kind of diabetes, but they're not yet available in type 1 diabetes. When I say that these therapies are transforming care, what I mean is that they're delaying progression of heart and kidney disease and reducing overall mortality. People with type 1 haven't been included in the clinical trials. And just like Courtney was explaining, in this field too, we're supporting clinical trials to evaluate these therapies, specifically in people with type 1 diabetes and long-term complications. This pyramid shows the current clinical practice guidelines for chronic kidney disease. And what you can see is that the 3 therapies which have boxes around them are labeled T2D, meaning that standard of care covers them for type 2 diabetes, but not type 1. And again, the reason is that they simply haven't been tested in type 1. The good news is that we're now supporting, and some others are supporting too, some of these trials to get the data. Courtney was talking about Ozempic, and this comes up again in the context of kidney care. We're also looking at sotagliflozin, which is an SGLT inhibitor, and our colleagues at Bayer are sponsoring a trial testing their NSMRA called Kerendia in people with type 1 diabetes and kidney disease. I must also point out there's a very exciting trial called STENO1, which is testing all 3 of these therapies together and is looking at cardiovascular and kidney outcomes. Now I'm going to tell you more about a trial called Sugar and Salt, which is one of the ones I just briefly highlighted. This is a pivotal trial evaluating sotagliflozin for kidney disease and type 1 diabetes. When I say pivotal trial, what that means is that if this trial is successful, the FDA may consider approval of it for an indication. This is a drug which has proven effective for treating kidney disease and type 2 diabetes, but hasn't been previously tested for kidney disease in type 1. The major issue with this drug and all drugs in this class is that it's been shown in other clinical trials to increase the risk of DKA, or diabetic ketoacidosis, in type 1 diabetes, and so this trial is featuring robust DKA risk mitigation protocols. It's a collaboration between us, the team of talented investigators, the manufacturer of the drug Lexicon, and the Kidney Foundation of Canada. It's currently enrolling across the United States and Canada, and we're very excited to see this move forward so we can try to get approval in type 1 diabetes. There are a number of barriers to the development of complications therapies for type 1 diabetes, and I'm going to tell you a little bit about some of these and what we're doing to overcome them. The first one is that pivotal trials for heart and kidney disease are extremely costly and complex, some of the most difficult trials there are to do. One way we're trying to overcome this barrier is by working with key stakeholders in the field to develop new kinds of clinical trials that won't be as costly, require as many participants, and take as long. The second challenge is that many complications therapies also affect glucose control. In a sense, this is a good thing to have a kidney therapy or heart therapy that also lowers your blood sugar if you have type 1 diabetes. However, it also creates a potential challenge in that if it's affecting your blood sugar, then you have to dose your insulin differently. And this may create the possibility of either going low or going high when it comes to blood sugar. And so in the clinical trials we're supporting, we're going to get the evidence on how to use these therapies both safely and effectively. Lastly, as I mentioned, a specific risk for the SGLT inhibitor class is that they're associated with an increased risk of DKA. As in the sugar and salt trial, we think the way to overcome this is sophisticated risk mitigation protocols, as well as picking the right patients for the trial and then in clinical use. In the future, there will be another tool that we think will be able to mitigate this risk, which is the CGM-CKM that Amin talked about. Again, this is a device which, in addition to continuously measuring glucose, will also continuously measure ketones, which when they rise too fast and too long, can cause DKA. So when you wear one of these and you're using an SGLT inhibitor, you'll get a warning and you can deal with it before the event happens. Last but not least, I'm going to tell you about the work we're doing in our psychosocial program. So psychosocial well-being in type 1 is a major problem. I'm not going to tell you about all of the statistics there are, but the important thing is that people with type 1 diabetes on average have higher levels of certain mental and emotional health issues than the general population, and that these issues are associated with worse clinical outcomes like high HbA1c. Our psychosocial strategy has 3 pillars. The first is to increase the number of trained psychosocial professionals. What we really need out in the field is people who both know how to help with mental health and understand diabetes, but there's not that many people with both sets of expertise, and so we're working to train more. The second thing we're working on is to increase the number of psychosocial interventions available, and the third is to improve the implementation of these psychosocial interventions, which show good data in clinical trials into real-world settings, and I'll talk more about these later. The other point we have to highlight here is that psychosocial research is integrated into all of our scientific areas, not just this program. For example, when we test a new device in people with type 1 diabetes, we'll include surveys in the clinical trial to understand how it affects people overall well-being, not just their glucose control. This slide shows some of the psychosocial interventions that are currently under investigation to improve different sorts of mental health outcomes in people with type 1 diabetes. You can see cognitive behavioral therapy, apps that allow people in rural areas to talk with someone who knows what they're going through on their phone, and other strategies like that. What all of these have in common is that we're testing them in clinical trials to see whether they both improve the targeted mental health outcome, and we also look to see if they're affecting A1C and other things that we think will benefit once mental health is improved. This is the pipeline for behavioral interventions. It's a little bit different from what we're used to thinking about with drugs, which go phase 1, then phase 2, then phase 3. I won't go through all the details, but the important thing is that even after you've shown effectiveness in a clinical trial for one of these behavioral interventions, you still have to do implementation work in order to get it just that implemented in actual clinical sites in the real world, and so that it can improve outcomes there too. A major challenge in the field is that this is a time-consuming and lengthy pipeline to actually improve people's outcomes. And so we're funding trials which are designed to shorten this pathway by doing multiple things at the same time. Recently, we funded 3 studies which are both developing effectiveness as well as data on the implementation of the interventions under development. The first 2, which are called STEPS and AHEAD, are aimed at helping adolescents and emerging adults in different geographies with different approaches. The third one, which is called Diet Better Mood, is about taking an app which was developed in Europe and has shown efficacy there, and adapting it and testing it in new geographies, in this case, in South America. If successful, these programs will be integrated into clinical practice as well as studied in future research trials to expand even further on their potential for dissemination, scalability, and evaluating the long-term durability of the interventions. Thanks for sticking with us through all of this. Now we just have a few conclusions for you. We started this presentation off by showing you where we've been and where we are now. And here we summarize some of the things we talked about, which we think the future holds for improving lives in type 1. We anticipate transformational new devices, which will improve not only clinical outcomes, but also equally importantly, quality of life. We're working on next-gen insulins and adjunctive therapies for glucose control and broader metabolic control, effective therapies for heart and kidney disease, and more effective therapies with improved usability for retinopathy therapies, and effective, widely available treatments for mental health. We're doing more clinical trials at Breakthrough T1D than we ever have before. These tables just show a smattering of the exciting things we're working on, including some of the trials we talked about and some other ones as well. We have 4 key takeaways from this presentation. The first is that the IL program supports research to improve health and quality of life for people with type 1. We're increasingly focused on therapy development, and we prioritize clinical trials above all else. We are working along with everyone else at Breakthrough T1D to foster a culture of clinical trial participation. There are so many ways that people can contribute to our cause, and enrolling in clinical trials is a great one. Clinical trials are absolutely essential to move forward the exciting therapies we're working on, and recruitment is often a bottleneck. If you're interested in learning more about any of the trials we mentioned or any others, please check out this link on our website called the Clinical Trials Connection Tool. Finally, we have to reiterate that the highest goal we think is to get a permanent cure for type 1 diabetes. But until we get there, the Improving Lives program is going to keep working to improve the lives of people who have type 1 diabetes today. Thank you all for your attention.